it is the top of the hour, so I think we'll go ahead and get started. My name is Elena Smith, and I want to welcome you to today's Regional COVID-19 Virtual Open Forum. And today's topic is focused on COVID-19 post-hospitalization. Let's talk. Today, we do have a special guest to add to the discussion, Dr. Hallie Prescott. Dr. Prescott is an associate professor of internal medicine in the Division of Pulmonary Critical Care at Michigan Medicine and a staff physician at the Ann Arbor Veterans Affairs Medical Center. She is the physician lead on the Michigan Hospital Medicine Safety Consortium, HMS, Sepsis initiative, and her research focuses on sepsis, performance measurement, and long-term outcomes after critical illness, and has been funded by NIH, AHRQ, and the Department of Veterans Affairs. She serves as vice chair of the Surviving Sepsis Campaign Guidelines, a council member of the International Sepsis Forum, and an advisory board member of Sepsis Alliance. We are so glad to have her and several of the HMS participants on the call today. To get us started, we have some housekeeping announcements. Please remember to mute yourself when you are not speaking and unmute yourself and state your name, state, and organization when participating. We do have representation typically on these calls from Michigan, Minnesota, and Wisconsin. If you are participating by phone, please press *6 to unmute yourself. Remember, do not disclose any personal health information if you are sharing. And if you have any trouble with Zoom, you can message Jessica Newsom in the chat box and she'll be able to help you out. If you have other questions or comments, please chat them to everyone. And lastly, today's call is being recorded and will be posted on our Superior Health QIO YouTube page in the coming week. That's also where you can find all of our past COVID-19 regional open forum calls. I want to briefly describe what is Superior Health Quality Alliance for all of our new participants today. We were formed in 2018 with 8 healthcare organizations across 6 states. Our partner organizations include 3 quality improvement organizations, 4 hospital associations, and the Midwest Kidney Network, which are all listed on the slide. We're all working together to achieve broad national CMS quality strategy goals. And our overall goal is to collaboratively improve the quality of health and healthcare for the consumers, patients, clinicians, organizations, and communities we serve. How do we plan to do this? Through addressing 5 strategic goals set by CMS, including increasing quality of care transitions, increasing patient safety, increasing chronic disease prevention and self-care, improving nursing home quality, and improving behavioral health outcomes. We will actualize these 5 goals through 3 unique strategies as shown in this image to meet your quality improvement needs. The independent approach is for self-guided learners who are able to implement change without much guidance. And we'll create things like e-learnings and toolkits within this approach. The affinity group strategy focuses on connecting participants virtually, and they're similar to this call today where we've met weekly, bi-weekly, and now monthly with a large group of participants who have shared their knowledge throughout each session. Our last strategy is a structured collaborative. These consist of small collaborative groups that allow for more technical assistance from our team and will include things like trainings and education using the ECHO model. Our services are offered free of charge, and we're excited to work with you. So if you are interested in joining our healthcare quality improvement efforts, please feel free to reach out to anyone on our team. Most of us have that Superior Health QIO tag in our names here in the chat, and we can email you after today's call. So now to get into today's topic, COVID-19 post-hospitalization and long-term effects. Tomorrow marks the 1-year anniversary of Superior Health hosting these regional COVID-19 open sharing calls. Since then, we've held a total of 23 calls where we've heard from so many of our participants and shared a great deal of what we've learned along the way. Back in June of 2020, we heard directly from a patient that was hospitalized with COVID-19, and at that point in time, we didn't know as much about what to expect post-hospitalization or about the long-term effects some experience months after their initial diagnosis of COVID-19. According to a study in the Journal of the American Medical Association by a team from the University of Michigan and the VA Ann Arbor Health System, including Dr. Prescott, for those hospitalized with COVID-19, the first week and a half post-discharge is especially dangerous. COVID-19 patients have a 40 to 60% higher risk of ending back up in the hospital or dying in the first 10 days compared to similar patients treated at the same hospitals during the same time period with heart failure or pneumonia. By the end of 60 days, COVID-19 patients' overall risk of readmission or death was lower than that for those with heart failure or pneumonia. In the first 2 months post-discharge, 9% of COVID-19 patients who survived hospitalization unfortunately died, and almost 20% had suffered a setback that sent them back to the hospital. That's on top of the 18.5% who had died during hospitalization. And this data highlights how risky the first 10 days after discharge are for patients with COVID-19. Another thing we've learned in the past year has been that there's a growing number of patients who recovered from acute illness that are still experiencing symptoms. This applies to patients who were hospitalized and those not hospitalized who had mild symptoms. We haven't been able to pinpoint how common these long-term effects are, who is most likely to get them, and whether the symptoms eventually resolve. These long haulers report things such as fatigue, shortness of breath, cough, joint pain, chest pain, difficulty with thinking and concentration or brain fog, loss of taste and smell, and even some vascular issues. It's clear that we still have so much to learn about COVID-19 in general, but especially when it comes to patients post-hospitalization and those experiencing long-term effects. Today, we hope to have an open dialogue with all of you about what you've learned in your role so that others can learn from lived experience. So with that, we do have some pre-created questions that are going to be shown up on the screen, but please don't hesitate to ask any additional questions that you might want to learn from the rest of the group. But to get us started, we did have a few. So my first question, and again, we want to hear from all of you, so please feel free to unmute yourself or add anything into the chat. Have you cared for patients with post-COVID-19 syndrome or that long hauler, or COVID-19 patients post-hospitalization, and what was your experience?
Yeah, great. Thanks, Elena. Thanks for the introduction and sort of background for this. It's a pleasure to be here. So I'll start sort of sharing some of my experience. So I work as a pulmonary critical care physician. So I treat patients in the intensive care unit with acute COVID. I also have just a general outpatient pulmonary clinic. So predominantly tend to see patients who have sort of chest or respiratory related complications. So I've seen, a number of patients who have had worsening shortness of breath, and the driving causes of that seem to really vary across patient to patient. We see a subset of patients, for example, who tend to have develop or sort of progression of fibrotic interstitial lung disease as a result of COVID, have chronic respiratory failure, sort of new or worsened oxygen requirement. So that's sort of one type of patient that I have seen in the clinic. We see other patients who have shortness of breath, however, whose pulmonary function is preserved, whose lung imaging looks normal. And so certainly their shortness of breath is not explained per se by lung impairment, but seems to be more driven potentially by sort of deconditioning over the course of the hospitalization. There's also been sort of a high rate seen in cohort studies of sleep disturbance and sleep apnea, insomnia, which a lot of times can manifest as exercise limitation or sort of perceived shortness of breath. And then the thing that I sort of have read about recently for shortness of breath is that some patients have sort of autonomic dysfunction type symptoms. So really elevated sort of heart rate, labile blood pressure, and that can be sort of a more tricky diagnosis to pin. But those are the sort of like broad things I think about when I see my patients in clinic with new or worsened shortness of breath. I've also seen a variety of patients who have had bothersome pleuritic chest pain. Really unclear kind of like why. Again, the patient I'm thinking of there had normal imaging, but whenever she took a deep breath, really got sort of diffuse pleuritic chest pain throughout her entire chest wall, didn't have underlying blood clots. We sort of still trying to figure out what's driving that for her. And then there's been other patients who have sort of new and bothersome cough. So I think like the sort of key thing is really that there's no kind of like one story fits all, but there's been really a variety of experiences across patients.
Yeah, thank you for sharing that. And I don't know if anyone else has anything to add to that, if anyone else has seen similar things with patients that they care for that wants to add. be kind of watching. If anyone has anything, you can feel free to place it in the chat or unmute yourself. And as a reminder, if you're joined by phone, you can press *6 to unmute yourself.
It looks like the next question is about patient education you've seen for those experiencing issues with persistent symptoms. I think I'm just looking at my notes here. I think I can put some things in the chat. Of course, you can go to the internet and there's just endless stuff. So this is just a few examples and there are many. Oh, it says chat is disabled.
Let me make sure now, is that working?
Yes.
Okay.
So a couple different things. Up to date, the Center for Disease Control and Prevention both have sort of handouts related to long COVID. I also put a thing from University of Michigan that is a sort of like a book about COVID that has different chapters. And this was made in conjunction with patients, families, and clinicians. So it was, I think, unique in that sense that it really sort of brings forth the patient voice and sort of patient concerns and also like sort of patient advice. I think there's so much uncertainty during the sort of COVID pandemic and, sort of information lags behind what people are experiencing. So I think a lot of people go to their friends, their neighbors, their social network to get answers. And so we tried to harness those answers in addition to sort of traditional medical advice for those resources.
Yeah, that is excellent. Thank you so much for sharing that. And now that we know that the chat is enabled, you can feel free to put your questions in there, or if you have any patient education that you've seen that's been really beneficial, we'd love to share that with the broader group here. So thank you, Dr. Prescott, for that. That's really helpful.
Looks like next question, have patients experiencing symptoms, I'm assuming long symptoms, been interested in getting vaccinated? And I just have like my sort of own anecdotal experience with the patients that I have had, but I would say most patients that I've seen that have had COVID are very interested in getting vaccinated because they've sort of had the lived reality of that was no fun. And we know that the immune response that you get from being vaccinated is much more reliable and we believe much more durable than what you get from natural infection. So the patients I've had have been very interested in getting vaccinated. And then recently there have been kind of reports I've seen in about patients experiencing improvement in long COVID symptoms after vaccinated. I haven't seen sort of formal medical literature about that, but like, hey, one more reason. We already believe vaccination is the right thing for these patients. This is just sort of one more, I think, piece of, one more reason why one might be swayed to get vaccinated.
Absolutely. And I know I've heard like a little bit, some anecdotal stories again, which is I feel like what we're getting right now about some people that had COVID in the past had sometimes worse symptoms after vaccination. Have you heard anything like that?
Yeah. Well, I think that makes sense. I mean, a lot of times, again, a lot of variation person to person, but it's generally thought that the second vaccination brings more symptoms because your immune system is kind of exposed the first time. And then the second time you get vaccinated, it sort of jumps even sort of maybe faster and has like a more robust immune response. And you can imagine that if you've already had a sort of a natural infection from COVID, then that first vaccine really is the equivalent of the second vaccine. And so your immune system has kind of already been primed. So I think that makes sense. But I actually, yes, I've heard that people have had a little bit more symptoms and, more achiness, maybe had to take a day off of work, but I haven't heard any kind of like horror stories that, oh my gosh, this was terrible and I wish I hadn't gotten that vaccine. Nothing has been to that level. I think everybody is like, yes, this is a sign that my immune system is having the appropriate response and making me more antibodies so that I won't, get truly sick, end up in the hospital or die from COVID, which is really, of course, what we're trying to prevent with the vaccine.
Absolutely. Thank you for sharing that. And I do know we have a question in the chat that I'll share. With the autonomic dysfunction, are you aware of possible connections to this being identified as COVID-induced POTS? I have noted some support for patients via Dysautonomia International.
Yeah, so I honestly confess I only recently have kind of become aware of this being reported. There was like a large article recently in the Atlantic talking about clinicians who run a lot of the large post-ICU clinics in New York, and they're seeing a lot of patients, and increasingly are sort of recognizing that patients have these kind of dysautonomic dromes. They did have quotes from sort of experts in autonomic dysfunction who sort of said it's not textbook for POTS, it's not textbook for any of these sort of like known types of autonomic dysfunction, but certainly shares a lot of features. And autonomic dysfunction, I think, again, presents kind of subtly, and a lot of times there's a delay in diagnosis. So it's important to have kind of a increased kind of awareness and sort of look out for that, because there's not any sort of real easy sort of quick tests. It's the kind of thing that you have to have a high suspicion for, I think, to be able to identify that in patients. So I was, glad to have read about it, because it's, again, another thing that I think about in terms of, is this lung dysfunction? Is this sleep? Is this deconditioning? Now, sort of autonomic dysfunction is one of those things that I consider when I'm evaluating patients.
Absolutely, thank you. It looks like our next question, and again, we want to definitely encourage anyone that if you have any questions, feel free to put them in the chat. If you want to add to any of these questions that are shown on the screen, please feel free to do so. Our next question is focused on how well are PCPs aware of post-hospital treatment practices, and what is the follow-up for patients after having COVID-19?
Yeah, this is an interesting question, right? So, a lot of my research is on the long-term outcomes and recovery from sepsis generally. So even, obviously pre-pandemic. And I think that generally awareness of what we would call post-intensive care syndrome, or sort of new or worsening cognitive, physical, mental symptoms following critical illness, was generally under-recognized. Like, you'd hear from a lot of patients that would say, oh, I went to my primary care physician. I sort of, told them about these symptoms. They did a few tests. Nothing really showed up in the test. And it kind of got minimized. And so the consistent thing I would hear from patients was that they didn't feel like their experience was being validated or sort of recognized, and they were kind of just told to like shrug it off. And I'm sure that this wasn't 100% of patients, but that was kind of a consistent thing that I would hear from patients that would sort of find me on the internet and email me. And I think one of the challenges was like post-intensive care syndrome was like really this like ICU-centric term for a syndrome. I don't think patients resonated with it. I'm not sure clinicians resonated with it outside of the intensive care unit. And it just sort of felt like a very medicalized, medical-centric like diagnosis. And I love the word long COVID because it was just organically developed by patients, like just describing what they're feeling. And I think it immediately resonates and people know what that is and people search for it. And there have been just all these support groups and sort of like patient-led like research and everything that's just kind of really sprung forth from just this kind of like need of all these people experiencing the same thing around the same time. So my sense is that the sort of longer term sequelae are much more recognized now than, we had a couple years ago from sequelae of a flu or other types of sepsis that, existed before. So my sense is that awareness has like really driven, because all of a sudden we have millions of people all around the world all experiencing the same thing at the same time. So we recognize patterns we didn't maybe see before. In terms of what is the follow-up of patients after COVID-19, so this is something that I'm very interested in. For the HMS, we partnered with a bunch of other quality improvement collaboratives in Michigan to have a registry of patients who are hospitalized with COVID-19 called the My COVID-19 Initiative. And we collected data from patients hospitalized at 38 hospitals across Michigan, and we telephone called at 60 days after discharge to ask how people were doing. And we also asked about their follow-up. And so we found, pretty substantial symptoms. About 40% of patients reported that they were not yet back to their normal activities 60 days after hospitalization. Similarly, about 40% of the people who had been working previously were not yet back to work. Those who had gone back to work missed on average a month after hospital discharge, and many returned with reduced or modified duties. So we found really impressive sort of longer term impacts on people's ability to function and kind of return to their normal activities. And then when we asked about their follow-up, we found that about half of the cohort had seen a primary care physician within 2 weeks, which I think would be the general recommendation after a hospitalization, to see a primary care doctor within 2 weeks. An additional 30% had seen a physician in the next sort of 2 months, but there was still 1 in 5 patients in our cohort who had been hospitalized and not seen a primary care physician within 2 months of discharge. And so to me, that suggests a gap, and that obviously we, there's been a huge focus, on sort of increasing the capacity of inpatient care, because that's been the kind of most urgent need. But I think that we also need to focus on trying to connect people, to outpatient follow-up after their hospitalization. and primary care, I think, is probably the most important thing for people to follow up with. There has also been there have been some clinics that are sort of multidisciplinary clinics to address the sort of multifaceted different potential outcomes or sort of sequelae people can have after COVID. And those, I think, are really few and far between. And so the access to those, unfortunately, I think is quite limited. But I think at the very least, it's really important to try to get people to follow up with primary care physician.
Yeah, thank you. And speaking of that, I think we have a question in the chat. Was there a way to collect reasons why some patients could not follow up with their PCP?
Yeah, like one of those things you wish you could go back in time and ask those things, right? It's interesting. So we have done some, we have sort of a paper in process right now trying to dig into this a little bit. And we saw a huge variation at the hospital level, even after we try to adjust for other things like, access to telehealth, which we got at the zip code level from different surveys that look at access to phones and computers, since most of the follow-up during that first surge really did occur by telehealth. But we found that even after we adjust for all of these things, that there was huge differences at the hospital level, that some hospitals had much higher rates of follow-up than other hospitals. And then it was interesting, and you dig farther, we collected information about whether that patients had a follow-up visit scheduled at the time of discharge. And there was massive variation from like 0% to nearly 100%. So some hospitals are just saying, yeah, go see your primary care doctor, do it. And others are saying, go see your primary care doctor. We have scheduled you an appointment. It is 10 days from now. Here is the date and time. And obviously that takes more work. But I think it's clearly going to result in more patients seeing it, because I think it signals that you care, that it's really important. If you sort of go to the trouble of actually making that appointment, and it suggests that you think it's really important, versus when you say, oh yeah, you should really do this. I mean, the discharge instructions also include a lot of things that one should do, like quit smoking and all this kind of stuff, and I think it just kind of goes over people's heads. So I also have my own parents and family members who are non-medical, and I know how hard it can sometimes be to navigate the medical system. Like they call in, they get put on hold, oh no, it's lunch, call back later. And then, oh, I need to schedule a follow-up appointment. Oh yeah, you can be scheduled in 6 weeks. And patients often don't know how to advocate for themselves to say, no, it's really important. I was just hospitalized. I really need to see someone within these 2 weeks. And so I think hospitals are typically much better equipped to be able to do that with patients, or at least teach patients how important that is. That's actually one of the key things I teach my own patients, is this kind of like self-advocacy. Like I will say, I'm scheduling you for a follow-up in 6 months because everything's going swell, or a follow-up in a year because everything's going well. But you are a patient with severe lung disease, and there's a risk that something could go wrong in the meantime, and I want to hear from you and I want to see you. And if you call back and say like, oh, I need an appointment, and they tell you, oh yeah, you can see Dr. Prescott in 3 months, like that's not good enough. Like tell them, oh, can you talk to her? Can you ask her if you can be overbooked? Like I tell them like what things they can say to try to get in to see me, to try to avoid the, oh, they come and see me and they're like, oh yeah, I've been having this horrible symptom for 3 months, because then I feel terrible. So I think it's a tough situation for people to navigate, even people who have sort of high levels of general literacy. Sort of navigating the healthcare system is a challenge. So bringing down those barriers to get follow-up appointments, or teaching patients like what are the things to say, and if you're not getting an appointment, what are the things you could do, or making your own like post-hospital follow-up clinic. Like, okay, we'll try to get people into their own primary care physician, but if for whatever reason that's not possible, their primary care physician is totally overbooked and just doesn't have capacity, like a lot of places will have like post, COPD exacerbation follow-up clinics or post heart failure clinics. And I think this is the same thing that you could have just as a general sort of post hospital follow-up clinic. Because you mentioned that that study we did in the VA. So we did see this like very heightened risk of readmission in those first 10 days. It was interesting, like the curve of time to readmission was very different after these other types of hospitalizations versus after COVID, where we really saw a lot of them in those first 10 days. And I have seen that like working in the ICU. I then went back and worked a 2-week block in the ICU shortly after publishing this paper. And it was like right at the tail end of this November to December surge. And I just saw like a ton of patients who got readmitted. And it like the ones that I tended to see were patients who came in, were on like 6 liters of oxygen. They were clearly getting better. They got tapered down. They kind of got stuck. They got qualified for home oxygen on 2 liters. They went home, and then things got worse and they came back and they were again needing these 6 liters. And I saw several patients like that. And I think the take home I have is it's a bumpy road, and some people have delayed worsening, and we've seen that consistently with COVID. I mean, in terms of should those people be kept in the hospital, like, I'm not convinced, because we also know that when hospitals are totally overloaded, that their ability to deliver quality care goes down, right? When you have surge. So you need to sort of balance this ability to have a manageable number of patients in your hospital, but also having safety at discharge. And this is where I think like telehealth, may be helpful, and also really counseling patients about what to watch for at home, both symptoms of worsening shortness of breath. Pulse oximeters can help. I think they're not the end all be all. We know that they're not perfect devices. So they're not the only thing. But I think just particularly because of this high rate of readmission and clinical deterioration in those first 2 weeks, even if they were on a trajectory of improvement at hospital discharge, is why this sort of relatively early follow-up with somebody is important.
That's super interesting. I think it highlights the care managers, their work and their role in all of this is super important. And I know we have another question about, was there a deep dive into the type of hospital that had 0% versus 100% follow-up, i.e. community, academic, large systems, et cetera, or higher performing versus lower performing quality?
Yeah, that's a great question. On the to-do list, we have not yet looked into that, but I suspect that there will be, some differences in types of hospitals. And so, yeah, stay tuned.
Awesome. Yeah, that seems like, I'm sure there is so much that you can do with what you've studied so far, so many other things you can look at. So that'll be really interesting.
Yeah, it's interesting. Like, I have shared some of these results with different physician groups, and it sort of, said that there was this huge variation. And sometimes I get sort of defensive responses like, well, their primary care person is like outside of our system, and like it's really hard to schedule follow-up and all this kind of stuff. And I keep thinking, like, if it's hard for you and you are like a hospital in the medical system, like, think over to the patient. And again, I think to my parents, who will frequently text me about how do I do this and how do I do that, who again, like high functioning, intelligent people, but they struggle, I think, to access the medical care system. And so I just try to put people back into the patient perspective, and think about, if it's hard for you, it's harder for them. Like, we're better equipped to do that.
Yeah. And I think your point about teaching a patient how to advocate for themselves is going to be even more important with what we know about people delaying care during the past year because of COVID, and not waiting when they have something going on to really advocate for themselves to seek out care. So I think that will be really important. So thank you for all the work that you're doing with your own patients on that. And I think that's something that we can all kind of take back and make a point in our own care. Yeah.
I think the other thing that's important at discharge is just sort of like who to get in touch with. I think a lot of times at hospital discharge, there's this tendency to say like, well, if anything comes up, just get in touch with your primary care doctor. But you haven't yet seen that primary care doctor. So I think there's this kind of like this like gap, like, where people feel very vulnerable, like before they've yet reached that primary care doctor. And like having been in that circumstance too, like, it's very helpful, I think, practicing in the ICU and then in this outpatient clinic, because I sort of see both sides of things. And I see my own patients, and sometimes they're hospitalized in different systems, and I'll just get this phone call like, patient was told to call, wants to know what to do about this. And I'm like, I haven't even seen the records of the hospitalization. I have like no idea. And you're sort of in this very difficult, you can give kind of pragmatic advice, but you're kind of like, without having the data of what happened in that hospital stay, it's challenging to really help.
Absolutely. Do we have any other questions from any of our participants? You can feel free to unmute yourself or add them to the chat. Well, while we wait, if you have any questions, you can feel free to still do that. Our next question is, have you heard of any support groups, which I know I heard you mention them briefly, or programs for patients and families?
Yeah, I mean, I think that like a quick Google search will bring up like tons of things. So I just put one in the chat right now, which is the Mayo Clinic has like an online chat, which now is for COVID, but they've been doing this for many years for post-intensive care syndrome, and it's actually moderated, which is helpful to ensure that there's, you sort of have some quality control in terms of the content there. So there's an ICU nurse who runs their post-ICU clinic who, runs this chat group as well too. So that's one that I've sent a lot of patients to. I think there's also some hospitals are fortunate to have kind of in-person or traditionally to have had in-person. I think now everything has really gone virtual. So some hospitals have these, but I think they're a little bit few and far between. So this one is great because it, can be accessed really by anyone. It's just open. And I think there's other ones on like Facebook as well too. So you mentioned that I'm on the advisory board for Sepsis Alliance, which is another patient advocacy group trying to raise awareness for sepsis and also the long-term sequelae of sepsis, which would include, from viral sepsis from COVID. And so they also have, Facebook groups as well too, and different support for patients. So I think there's a lot of, stuff out there. And honestly, I think the term long COVID has done more to raise awareness and raise support than anything else, honestly, in the past 5 to 10 years.
And we do have another question in the chat. I know this is primarily an inpatient question, but what links have you seen between COVID and severe sepsis or septic shock? Is it a result of the viral load from COVID or more so a secondary infection like pneumonia?
Yeah. So I think, sepsis is like a pretty inclusive definition of essentially organ dysfunction due to your body's response to infection. So anybody who has respiratory failure due to COVID, I would consider that as essentially severe sepsis due to COVID. In terms of, these kind of secondary infections, there's a lot of concern in the beginning that patients would have bacterial superinfections like we see sometimes with influenza. And that has been relatively rare for COVID, at least for the beginning. So when people arrive to the hospital, bacterial co-infection is very rare. So we've looked at this in the COVID-19 registry, and it was less than 4% of patients had a bacterial co-infection on arrival to the hospital. It's a different story for patients who get critically ill, end up in the ICU or on the ventilator for a long time. There's, patients are of course at risk for then developing sort of infections as a result of their sort of prolonged critical illness, but just coming in the hospital, that's pretty rare. And then in terms of the sepsis, I think the big things we see consistently is, it's predominantly a respiratory virus. So that's the most common kind of organ dysfunction we see is needing supplemental oxygen or higher levels of respiratory support, heated high flow or mechanical ventilation. But we also see a fair amount of shock. I think in my COVID-19 registry, about 15% of patients were treated with vasopressors. And then we also see some, kidney dysfunction as well, too. But I think it was only like 4 or 5% requiring dialysis. So the sort of distribution of the organ failure is a little bit different than if you just looked at all comers with sepsis for any cause, because it's very different, for example, from people who have sepsis from, for example, a urinary tract infection, where predominantly they would present with kidney dysfunction and low blood pressure, but rarely sort of end up on mechanical ventilation because that tends to respond very promptly to antibiotics. So a little bit different in terms of how patients have presented.
Thank you. I know we've kind of mentioned this a couple times, but is that long hauler, the long COVID-19, post-COVID-19 syndrome recognized as an actual medical condition at this point in time that would warrant an ICD-10 code or anything like that?
Yeah, so I'll put this in the chat. So this is the code that I'm aware of. There's one for sequelae of COVID-19. So I think that you could, like if you were seeing somebody, for example, in Followup, you would code the specific symptoms that they're having, or perhaps the specific diagnosis they're having. Like, I might see someone in code fibrotic interstitial lung disease and also sequelae of COVID-19 if they think that's what's driving it. So again, I still think it's like a very broad, like umbrella term, and there's a lot of different sort of underlying, pathophysiology of what's happening. It's not like you have coronary artery disease, like this very precise diagnosis, and it's like, really consistent what's happening person to person. I think these kind of longer term life-altering effects of COVID-19 are so variable across patients. I think, I think that it's gonna, my personal thought would be that it makes more sense to, name and label the specific things people are experiencing, either symptoms or diagnoses, and then also label this as, a sequelae of COVID-19 based on, oh yes, this definitely showed up right around the time, or, progressed significantly around the time of COVID. I think that there's a lot of different groups right now trying to work to develop more sort of precise or sort of consensus definitions for what does this mean and what are the diagnostic criteria. So I know the NIH has a large call out for applications for what they're calling PASC, or post-acute SARS-CoV-2. Post-acute SARS-CoV-2. So, and then I think there's a Canadian-wide effort right now to sort of bring together people to, experts to kind of present their data, talk through the issues, and try to decide what is the definition, what are the diagnostic criteria. But I think, those things are a little bit right now in their infancy. And I will say that, we've been dealing with the same things for post-sepsis for a long time, and there's not diagnostic criteria for that either, or probably even truly a consensus of what that means. And there's a lot of these kind of overlapping concepts of post-intensive care syndrome and post-sepsis syndrome, and there's even this post-hospital syndrome. And I think it's a kind of a messy exposure. I mean, when you say sequelae of COVID-19, I mean, there's the actual viral infection. There's the, oh, you got critically ill and ended up in the hospital and were, relatively in bed and not doing your normal activities for 2 weeks, or, oh, and then on top of that, you were on mechanical ventilation and sedation. And then, oh, in the background, you're living in a time when there's all this great uncertainty and you're, estranged from your families and friends. And, maybe there's been economic impacts and you've lost your job. So when you try to measure the impact of COVID-19, there's all these different things. So of course you're going to get this very broad potential outcomes that are going to look really different patient to patient. So, but for now we've got B94.8, ICD-10 for sequelae of COVID-19.
Yes, thank you for sharing that. That's such a good point with all of the background things that are happening just outside of the actual illness.
Oh, I know. If you look at a GAD or whatever, the generalized anxiety disorder questionnaire, I read that sometimes and I'm like, oh yeah, I think I can endorse all of these things. I mean, it's been a really stressful, 13 months now for everyone.
Right. Absolutely. And I think you kind of touched on this already, that we don't have the minimum number of symptoms reported by a patient to be able to use that code or anything like that. We're still learning, and sounds like there's a lot of groups that are doing all the work to really hone in on what this will look like.
Yeah, I'm sure this will evolve a lot. I mean, there's a ton of interest in this right now. The NIH, the VA, other countries, I think there's a lot of initiatives. And so this will be I think a moving field for the next few years.
So for those that are experiencing ongoing symptoms, are there specific treatment options available for them right now, and anything you would recommend for them to seek out?
Yeah, I mean, the sort of general way I sort of approach this is for people who come and are having new symptoms, I think it's helpful to kind of screen for, what are the common things people are having? Are they having, cognitive issues like memory problems, confusion, inability to complete their activity or instrumental activities of daily living. And for those people, I think occupational therapy can be very helpful, not necessarily to fix the lesion or the problem, but to help people adapt to that and still go about and do their normal activities. And then I think sort of general, I mean, it's really we're got pragmatic recommendations of, I sort of really encourage this kind of concept of use it or lose it, of reading and books on tape and crossword, whatever you're able to do. There's not a lot known about cognitive rehab from critical illness in general. We've looked at this recently for the Surviving Sepsis campaign guidelines, and there've been sort of small pilot studies that have been very promising, but they're, on the order of 20, 30, 40 patients. So there's definitely not going to be guideline recommendations on what to do. And so I think these kind of pragmatic solutions, but I think occupational therapy and sort of promoting progressive, graded increases of activity to kind of use the brain, and just same thing with graded physical activity as well too, for people who are experiencing dyspnea and exercise limitation. So that's kind of the cognitive stuff. I mean, I think I see a ton of people in my clinic, of course, shortness of breath and, physical deconditioning. And I think that you really a lot of times these things are multifactorial, like people are not sleeping well, they maybe have anxiety and depression, they're deconditioned, again, if they have any of this additional kind of autonomic dysfunction going on. So I think it's trying to, sort of screen for those different things and figure out what do you think are the primary things driving this, right? If people are sleeping 3 hours a night, it doesn't matter how many inhalers I put them on, they are not going to feel well, right? So I try to take a broad idea of what are the key drivers and what are the treatable drivers, right? So I talk about sleep a lot because I think actually for sleep apnea and sleep disordered breathing, we actually have some of the best treatments in terms of you can take someone who has horrible sleep, and if they're able to sort of, if they have sleep apnea and they're able to tolerate a mask, it's night and day. I mean, people come in and they're like, oh my gosh, I'm a brand new person because I went from literally not sleeping, never really being asleep and never really being awake to oh my gosh, now I sleep at night and I'm awake during the day. And so that's one I really focus a lot on just because I think it's so treatable and it can make such a big difference for patients. Pulmonary rehab and structured exercise programs. I think I see a ton of people who come to clinic with worsening shortness of breath, and the default assumption for a lot of people is their lung function has worsened. And because I see a lot of people in pulmonary clinic, I also see a lot of people who had pre-existing lung disease, and we have longitudinal pulmonary function tests. And I would say the absolute majority of patients, their lung function is the same, 3 months after, COVID or 3 months after pneumonia. And, a minority and an important minority do have worsening of lung function, and that's kind of a different treatment algorithm. But a lot of people, get in what I call the vicious cycle. They have lung disease, but they're sort of well compensated and they're well functioning. Then they get sick. They're in bed for a lot of time. They're not able to do their normal activities, and sort of getting back in shape. You all know how hard it is to get in shape. Now imagine trying to get in shape, but you already have some lung disease. It's hard work. And I think the default assumption when people go out to try to do that hard work and they get short of breath and they can feel their heart rate go up a little bit is oh my gosh, I might be really doing harm to myself. And then you go to the gym, or you used to go to the gym, and there's a sign on the wall, do not exercise without talking to your doctor. And that reinforces this notion of oh my gosh, you're doing harm. And so I see these patients who say, well, I've been sitting on my couch waiting to get better. And I'm sitting on the couch is not a good recipe for recovery. So I think this is where this counseling comes in. And for people who are sort of very afraid about exercising and what is safe, physical therapy and pulmonary rehabilitation can be super helpful because they're in a monitored setting. They have their heart rate monitored and their pulse ox monitored and their respiratory rate monitored, and they can push patients, but not too much that it's unsafe and they're going to pass out. But they can also monitor their progress and say, oh, you did this many minutes on the treadmill at this and this pace, and 3 weeks later, look what you're doing. And so that's really helpful. It's not, not every patient can go to pulmonary rehab. We don't have pulmonary rehab, so for every single person, or they don't all qualify. So for other patients, I counsel them about this, and I say wherever you are, start there and do a tiny bit more. And for a lot of people, they can't push for long periods. They can only exercise. I can only walk for 3 minutes and I am so fatigued, I am short of breath. I'm okay, do 3 minutes. But 3 hours later, do another 3 minutes. And then 3 hours later, do another. And that tends to be more effective than just trying to I'm going to go out and do 30 minutes of exercise. It's just not feasible. And then people get really kind of bummed out and depressed, they're not going anywhere. So I think it's really important for them to log exactly to the 30 seconds, how much exercise, they did, how far they walked, how many times around the block, and then just keep that log. And they'll come in and they'll be oh my gosh, when they can see that progress, it's so motivating. And I think sometimes I'll hear too, patients will talk to somebody and then someone will be oh yeah, you should go out and do 30 minutes of this. And it feels really, they're I can barely brush my hair, and you're telling me to walk 30 minutes. It's very defeating. So I have to be very careful, be what can you do right now? Okay, we're going to do this. And then you're going to do it again in the afternoon. So trying to meet them where they are and talk about the importance of graded increase and tracking progress and sort of reinforcing that small gains are super important. And that honestly, sitting on the couch, you're actually getting worse. So sometimes even maintaining is actually better than what might have been happening if you weren't doing that hard work. So I'll get off my soapbox now.
No, I think that's so important. And I imagine that would be that the lack of motivation and must be exacerbated. I mean, we usually have representation from Michigan, Minnesota, and Wisconsin. So we've have been in the cold for so long that getting outside and getting that exercise is so much more difficult now that it's getting a little nicer in all 3 locations. I'm sure that is definitely a big motivator as well.
Yeah, we've been very fortunate to have a better spring this year. It's been warmer. People have been able to get out because a lot of my patients, like used to go walk in the mall and stuff, but now with everybody kind of sheltering, that hasn't been possible. So it's been harder. And so again, it's like walking up and down the stairs or like, walking up and down the block, like whatever, you can do. But yeah, you have to help people think creatively and also sort of recognize that even small bits of exercise are really important. Even like incentive spirometers, like for people who are really debilitated, I have them do like breathing exercises on incentive spirometers to like specifically focus on their respiratory muscle sort of strength training. And that can be really helpful for patients as well too.
Yeah. Well, thanks for sharing that. I do want to open it up again. Does anyone have any questions they'd like to ask? I know we usually have representation from home care on the call. If any of you have any questions, or any nursing homes, if you have questions in relation to anything we've talked about today, feel free to ask those. You don't have to have them exactly fit the questions shown on your screen right now. Well, I can ask one last question, I think. So recent articles are showing that COVID-19 can make changes to a patient's vascular system. Are there concerns that these changes will negatively impact other health outcomes in the next few years?
Yeah. So I'm not exactly sure like which studies that is like sort of talking about. I guess I'll sort of answer in a couple of ways. I mean, there's some studies that do kind of like really, I don't know, like imaging studies or sort of like more precise screening studies. And I'm always a little bit like hesitant to know the clinical significance of these things. Like we're very good at sort of picking up stuff like, a lot of these studies have looked at like pulmonary dysfunction afterwards and done high resolution CAT scans, and it'll be like abnormal, but it's like, 3 pixels up here, had a little bit of fibrosis. Like, I'm like, I don't know what to, do with that. So I'm always a little bit skeptical of things like if it's some test that you're not already using in clinical practice, but just a super sensitive thing trying to find like underlying, something you can measure. That being said, in terms of whether people are at risk for longer term things, I think absolutely like there is this possibility that people are at risk for sort of stuff later. Like we've done studies looking at, increased risk of mortality after sepsis generally, because there's been this kind of notion with sepsis that, well, there's a high rate of mortality in the years after sepsis, but that is a marker of the people who get sepsis being older, having more comorbidities, and therefore this is not surprising. But we did like very careful studies where we matched people who had sepsis to very similar people who were hospitalized for other causes, and either people who were in the community, but had, similar age, comorbidity burden, like number of hospitalizations, trajectory of health over time, functional capacity. These were patients who were participating in this health and retirement study, which is a huge like longitudinal cohort study about aging, kind of like a Framingham cohort. So we had really detailed information, longitudinal information, and like to the best that you're able to, like makes otherwise similar patients to really like isolate the impact of sepsis. And we found that we could measure an increased risk of mortality to 2 years afterwards. So I think absolutely there is a possibility that this could lead to sort of like small increases of risk for sort of subsequent things, down the stream. Whether these, imaging studies are going to be helpful in terms of like stratifying people, I'm a little bit more skeptical, but yeah.
Well, thank you for sharing all of that. And I think it's something that we'll all have to be paying attention to in the years to come. So thank you so much. I do, if you have any more questions, feel free to ask them. That goes to everyone. But in the meantime, I'm going to ask Jessica to please place an evaluation in the chat. If you'd like to take that for us and let us know how we can improve future calls, please let us know. With that, I do want to thank Dr. Prescott and all of the HMS participants that joined us today. Thank you so much for sharing your knowledge. We really appreciate you taking the time to be here, and thank you for all the great work that you're doing and researching all of this and caring for so many patients. We really, really appreciate it.
Great, thanks. My pleasure. Thanks for the great questions.
Thank you. And with that, we will end the call. So thank you everyone for joining us. I know our next call will be on April 22nd. It'll be at a different time, and that one is going to be focused on vaccine efficacy. So that will be a 3-part series that will actually happen bi-weekly. Although these calls have been monthly, we're going to have a bi-weekly series focused on vaccines. So be on the lookout in your inbox for that invitation. We thank everyone for joining us today, and we will see you on April 22nd.